Muchas gracias, Liliana, por la presentación. Quiero agradecer también mucho al público por las distintas preguntas que estamos tomando y estamos trabajando y vamos a seguir discutiendo durante la sesión de preguntas y respuestas, porque realmente es el momento que creo más va a construir de esta actividad. Vamos a dar paso a la última charla de este bloque. Esta charla va a estar llevada adelante por el doctor Brian Weinshenker. Es un enorme placer presentar y darle la bienvenida a este simposio al doctor Weinshenker. El doctor es profesor de neurología y consultor en la Mayo Clinic en Rochester, Minnesota. Él nos va a hablar sobre la elección del tratamiento y la respuesta subterapéutica. Es una situación y una instancia que más complicaciones muchas veces nos genera desde la práctica clínica. Adelante, doctor Weinshenker.
Hello, I'm Dr. Brian Weinshenker, a neurologist at the Mayo Clinic in Rochester, Minnesota. And I'd like to thank Dr. Carnero and the organizing committee for inviting me to speak at this meeting. I'm sorry because of COVID that I cannot join you in person. I've never been to Argentina. It's a place that I've always wanted to be, but I'm sure one day I'll have the opportunity. I've been asked to speak with you about treatment choice and what to do in the event of suboptimal treatment response. In the last talk, you've heard about the various treatments we use as maintenance treatments for neuromyelitis optica spectrum disorder, so I will pick up from there. These are my disclosures, and I would say that for all of the new approved treatments, the 3 regulatory approved treatments for neuromyelitis optica spectrum disorder, I have had some role in the clinical trials, and 2 of them, as shown at the bottom, I served on the adjudication committee for the Elección clinical trial of eculizumab and the Viela Bio clinical trial of inebilizumab. I've also consulted on satralizumab clinical trials with Chugai, Roche, and Genentech. In terms of treatment of neuromyelitis optica, I think we all think about these recently approved treatments and maintenance treatments, but a critical part of management of neuromyelitis optica is treating acute attacks. Unlike multiple sclerosis, where most attacks are mild and will recover spontaneously, and certainly after a course of corticosteroids, they recover quite well in the vast majority of patients. This is not true for neuromyelitis optica. Certainly there can be spontaneous recovery, but attacks tend to be more severe, and it is very common for attacks to leave residual disability, often quite severe. So the immediate management of attacks is a critical part of the management of neuromyelitis optica. The general recommendations are that treatment should be initiated as soon as possible. Unlike a patient with multiple sclerosis, where we might get a phone call from the patient and we'll ask them to perhaps observe over the weekend and see how things are going before they come in for an evaluation, a patient with neuromyelitis optica spectrum disorder, especially one who is seropositive for AQP4 IgG, needs immediate assessment and treatment if it is felt to be an attack. And generally, high-dose corticosteroids are the standard of treatment. A typical regimen is 1 gram per day for 5 days. And if there is no improvement within a short period of time, unless there's clear evidence of progressive and significant improvement, we often consider plasma exchange. Many patients who are treated with high-dose corticosteroids will get a tapering course of oral prednisone. One thing that we see in a number of patients with neuromyelitis optica spectrum disorder is almost a dependence on corticosteroids, and if corticosteroids are withdrawn, they may relapse. Now, you may ask, what is the evidence base for these recommendations? And in fact, we have very little in the way of a good evidence base for the recommendation of high-dose corticosteroids, which we've really borrowed from experience with multiple sclerosis, although I think there can be little doubt from extensive experience that high-dose corticosteroids are very commonly effective. In terms of plasma exchange, in my own opinion, the definitive study that provides us with a real evidence base is a study that I and my colleagues conducted at Mayo Clinic in the 1990s. It was a randomized sham-controlled clinical trial of patients with severe demyelinating disease. Many of the patients had myelitis. There were a small number of patients who we actually diagnosed with neuromyelitis optica, although I suspect that a number of the patients who we enrolled with myelitis actually had neuromyelitis optica. When we conducted this study, we didn't really have good criteria to recognize neuromyelitis optica at the time. But this was a sham-controlled randomized study of 22 patients. And we observed that approximately 55% of the patients who were receiving active plasma exchange experienced moderate or greater recovery, whereas this occurred in fewer than 5% of the patients who were in the sham-treated group. So I think this provides us with a good, strong evidence base. And since then, there have been a number of small reports, a small series of patients that with neuromyelitis optica, many, if not most, who were AQP4 IgG seropositive, where very significant improvement was documented after plasma exchange. A retrospective study was conducted by my colleague, Dr. Ingo Kleider, along with the NEMOS group in Germany. This is a multi-center collaborative interest group in neuromyelitis optica, and they retrospectively reviewed their experience in 207 treated attacks in multiple centers, and they categorized the outcome, and this was retrospective, of course, as complete remission, partial remission as shown in the green, or no remission. And a number of things were found in this study. Firstly, that it was unusual to get complete remission with corticosteroids alone. And after the first line of treatment, whether it be corticosteroids, which was used in the vast majority of patients, or plasma exchange, which was used in a much smaller proportion, and an even smaller proportion received other first-line treatments, it was found that if a patient failed and was switched to another treatment, say, for example, steroids to plasma exchange or plasma exchange to steroids, there was always some increment in improvement. That is, the patients who achieved complete remission were more frequent after 2 treatments than if the treatment was stopped after the first treatment. So it did seem useful to add additional treatments. One interesting thing in this study was especially patients with myelitis. It was found that if plasma exchange was used as first-line therapy, and this was done in only a very small percentage of patients, the chances of achieving complete remission were much greater. And as shown in this bottom panel, complete remission was much more likely, up to 40% in patients who received plasma exchange within the first 2 days, compared to those who received plasma exchange after more than 7 days, where it was only 2 or 3% of the patients who experienced complete remission. So receiving plasma exchange as a first-line treatment in this study, admittedly a retrospective study with bias in choice of treatment, and only a small percentage of patients receiving plasma exchanges as first-line treatment, it did seem that plasma exchange may be more effective than corticosteroids, but of course plasma exchange is a rather complex and expensive treatment. Corticosteroids are easy to start immediately. I would still use corticosteroids as first-line treatment, but I think it helps support a number of other studies in the literature suggesting that plasma exchange is a valuable rescue treatment. And I think this bolsters the result from the sham-controlled study that we conducted at the Mayo Clinic and was published in the Annals of Neurology in 1999. So this was a review of management of neuromyelitis optica spectrum disorders and also MOG-associated disorders that was published in Nature Review Disease Primers very recently, just a few months ago. The senior author was Yarius. I was pleased to be one of the co-authors. And after a very detailed review of the literature, which is very well summarized really in great detail in that review, which I'd recommend to you if you are interested in getting the full details behind all these recommendations, came up with this algorithm, which is more or less what I showed you at the beginning. Treat initially with high-dose intravenous methylprednisolone. If that fails, use plasma exchange, or if you're in a country where immunoadsorption is available, essentially that seems to be equally effective. There's some studies which suggest IVIG might be a suitable replacement for plasma exchange, but many fewer studies and not high-quality studies. So my own feeling is that if plasma exchange is available to you, you should use that rather than IVIG. And if that fails, I think we really don't know what might work. Some may give more intravenous methylprednisolone. Some, if they've given plasma exchange, might treat afterwards with IVIG. Some have found some success by early initiation of targeted therapies such as rituximab or cyclophosphamide, but I think this is a situation, this bottom box, that we really don't know what works or if anything works. But Dr. Yarius suggests that there is limited evidence that suggests that for first-line treatment, plasma exchange may be a reasonable alternative. As I said, my own practice is to treat with high-dose intravenous methylprednisolone for 3 to 5 days. If within 3 days I don't see clear evidence of important improvement, and I'm not talking about a patient who's completely paraplegic who starts to wiggle their toe. I'm talking about significant improvement in strength, then I will immediately escalate to plasma exchange. Well, let's turn to talk about relapse prevention with the treatments that you've heard about in the last lecture. And I'm sure you've heard about various oral non-specific immunosuppressants, and I won't go through these in detail. The most commonly used are azathioprine, mycophenolate mofetil, quite often combined with oral prednisone, especially for the first 3 to 6 months, because it does take 3 to 6 months for azathioprine and mycophenolate to take effect. Methotrexate is also an option, or mitoxantrone has been reported to be effective. So we have these treatments. Prior to describing to you how I use the new drugs compared to the old drugs, the new drugs being eculizumab, inebilizumab, and satralizumab, I'd like to review a few facts and compare these new drugs with the old drugs. The first thing to let you know is that the new drugs are extremely expensive. Satralizumab is $219,000 in the first year and $190,000 US per year subsequently. Inebilizumab, $393,000 in the first year, $262,000 in subsequent years, and eculizumab is $710,000 US dollars per year. The old drugs, the cost is variable, but they're much, much less expensive. And we're talking about costs that are generally under $10,000 a year. We'll talk about rituximab in the next slide. The new drugs, of course, are regulatory approved based on rigorous phase 3 clinical trials, which is certainly worth a lot, whereas the old drugs, the evidence base is mainly retrospective or small uncontrolled case series. However, the new drugs, the data we have is prevention of the first on-treatment attack. Only a single attack was allowed in these clinical trials for ethical reason. So yes, we have rigorous data, but based on very little information for each patient. Whereas the old drugs, although the data are less rigorous, we do have quite a long experience of safety and with apparent efficacy, certainly for those of us such as myself who are older, who treated patients with neuromyelitis optica before we knew any treatments were safe. There's little doubt that there was a big difference when we introduced azathioprine and mycophenolate mofetil. The new drugs are highly targeted to the pathogenesis of neuromyelitis optica spectrum disorder, which in theory might make them safer, whereas the old drugs are non-specific immunosuppressants, and these could have more collateral side effects, gastrointestinal side effects, and so forth. The new drugs do have a very good safety profile, fortunately, in all of the clinical trials, but these are short-term studies. And we have seen from studies of IL-6 inhibitors in patients with rheumatoid arthritis or other B-cell depleters like rituximab in patients with NMOSD and in other conditions that over time, there appears to be some increased risk of serious infection. It's not a very, very high risk, but a significant risk. And as we'll talk about with rituximab in the next slide, may be associated with hypogammaglobulinemia. The old drugs have generally a pretty good safety profile. We've used them in a number of chronic autoimmune and other diseases, but there is certainly evidence of an increased risk of infection with many of these, and there are other collateral side effects, hematologic and so forth. A special instance is rituximab, B-cell depleter, and of course we have a new B-cell depleter in ebolizumab. They target different proteins. In ebolizumab targets anti-CD19, which is also present on mature plasma cells and plasmablasts, which might render it more effective for neuromyelitis optica, at least in theory. Rituximab targets CD20. In ebolizumab is humanized, whereas rituximab is a chimeric antibody. Humanized should be better. So that is a difference. Ebolizumab has been studied rigorously in a large phase 3 clinical trial, whereas rituximab, we primarily had open label experience, but as I mentioned, there was a recent randomized small clinical trial, placebo-controlled, run in Japan in 38 patients. And it was very impressive how rituximab, there were no events compared to about 37% who had attacks in the placebo group. So a very big difference. Ebolizumab has had regulatory approval. Rituximab approval has not been sought. There's a major difference in cost. I've mentioned the cost for ebolizumab. Rituximab is about $30,000 a year, and we have biosimilars that are even less expensive. The safety profile was extremely favorable in the clinical trial of ebolizumab. Rituximab, the safety profile is also favorable, but longer-term experience that we have, and we have a few studies from Italy and from the UK that have studied patients with mean follow-up of approximately 5 years or so. There does seem to be worsening hypogammaglobulinemia over time, and a fairly high percentage of patients who have severe hypogammaglobulinemia had serious bacterial infections. many of them treatable, but this is an important risk. So comes down to the question when to choose these various drugs. Should we stick with existing drugs or use new drugs? And the answer may be different in new patients. New patients, I tend to use one of the regulatory approved treatments. Certainly in patients who fail an existing treatment, I'm inclined to start on one of the regulatory approved treatments. But for patients who have been stable for many years on current treatments, I'm rather reluctant to switch. Ideally, I'd like to tell you that based on our understanding of the mechanism of neuromyelitis optica, and that the astrocyte is the main target, and aquaporin 4 is the main target protein, and we've learned a lot about the biology of this disease. I'd like to tell you that we could measure some biomarker and individualize based on the drug mechanism of action. But to our understanding, all of these various mechanisms are operative in patients who have AQP4 IgG seropositive neuromyelitis optica. And at this point, based on mechanism of action, it's not really possible to individualize treatments. We can consider patients' individual comorbidities and safety risks, although we don't really recognize any specific comorbidity or safety risks that allows us to choose one drug over the other. The main reasons that we end up choosing one drug over the other tends to be cost, convenience, and availability. And convenience, of course, differs between these drugs. Many would regard inebilizumab as a highly convenient drug because it's administered as an infusion, but once every 6 months, whereas eculizumab requires every 2 weeks intravenous infusions. Satralizumab is self-administered, so that does make it somewhat more convenient, but some patients are reluctant to give themselves injections. So this will depend on individual patient perceptions. Should we use a single treatment, or should we keep patients on combination treatments, perhaps azathioprine plus add one of the targeted therapies? In the clinical trials, it was not clear in the 2 clinical trials that allowed patients to stay on their existing treatment whether there was any added benefit over the targeted therapy. And likely there is some increased risk of infection, does add to cost. So I think for all of those reasons, most of us are reluctant to recommend, at least in patients who are not failing multiple treatments, that you start single treatments, that you start multiple treatments. So we'd recommend in the vast majority of patients treating with a single agent. What do we do with seronegative patients? In the 3 clinical trials that allowed patients with seronegative disease to enter, it appeared that the efficacy was less, and in the 2 satralizumab studies, there was really not even a trend to efficacy in the patients who were seronegative for AQP4 IgG. So I think most experts would recommend against the use of these new approved agents. I think we don't know about rituximab, but the new approved agents, I think most would recommend against using those in seronegative patients. I must say that when I'm not certain about the exact pathogenesis in a group of patients, and that probably applies to the seronegative patients, I tend to use more non-specific drugs. I have a feeling that the efficacy is less dependent on a very precise understanding of the pathogenesis. Now, how do you monitor treatment and when do you switch? Largely based on, of course, efficacy and safety. Efficacy, we tend to judge mainly clinically. Unlike MS, where we see many patients having silent lesions, this seems to be much less common in patients with neuromyelitis optica spectrum disorder, although a recent report, not yet published, from the inebilizumab study suggests that we might be greatly underestimating the frequency of silent optic nerve lesions especially, but even other lesions in the central nervous system. But at this point, most do not recommend routine monitoring, say yearly or every 2 years, of MRI scans of the brain and spinal cord to pick up subclinical lesions. I think a promising surrogate is serum GFAP, which can be measured using the Simoa technique and was recently shown to be elevated in a substantial proportion of patients with neuromyelitis optica, and elevations seem to predict attack. And certainly with attacks and just preceding attacks, the levels seem to rise. So I think this is a promising surrogate, but much more needs to be done before I could make a recommendation about using this still not very widely available method of monitoring the disease. GFAP, of course, is a structural protein of astrocytes. Safety monitoring, principally measuring serum immunoglobulins, quantitative immunoglobulins in patients on inebilizumab. How do we define treatment failure? I don't think there's an exact definition. It depends on the severity of attacks, the degree of recovery, and how many other agents have tried. If you've gone through 3 or 4 other agents and the patient is on eculizumab, I think you're going to have a higher bar before you say that the patient failed treatment. But in general, any patient who has a new attack, especially if severe, warrants consideration of treatment changes, especially if the patient's on a non-approved treatment. If a patient has a very mild attack with good recovery, this may still represent efficacy of the treatment that the patient is receiving. It's possible that these treatments not only reduce attacks, but mitigate their severity. And I would not routinely change treatment if a patient had a very mild attack with good recovery. We've talked about silent MRI lesions, and at this point, I think it's too early to recommend routine monitoring. There are certain things that shouldn't represent criteria to declare treatment failure and switching treatment. Paroxysmal tonic spasms, which are very common in patients after myelitis, are best treated with carbamazepine. They will remit after 6 months. So usually you can taper and stop the carbamazepine, but very important to recognize those. Persistent disability, worsening spasticity, or transient worsening of symptoms not associated with new lesions on MRI, so-called pseudo attacks, also are not reasons to declare treatment failure. And again, we come to this review in Nature Reviews Disease Primer by Yarius et al. It's a very complicated slide, but I can simplify it for you. Basically, it says that any of the treatments we've talked about, rituximab or any of the new approved treatments, can be considered first choices, and alternatives include the other oral therapies, which depending on availability may be the treatments that you might choose. But I think as a first-line treatment, quite reasonable. And if the patient fails, again, what looks very complex comes down to a very simple recommendation, and basically that you can choose any of the other treatments as an alternative. The only exception is in patients who are treated initially with either rituximab or inebilizumab. This review suggests that because they have similar mechanisms of action that you might want to choose a different treatment. Having said that, I don't think that this is a very strong recommendation because, as we've talked about, inebilizumab targeting a broader swath of B cells may have advantages over rituximab. So I think it is a reasonable option in the event of rituximab failure. There are a number of future potential treatment strategies, which I won't go through in great detail. Bortezomib has been reported in patients with neuromyelitis optica. This is a proteasome inhibitor that more specifically targets mature plasma cells, and has been reported to be effective in a very small number of patients treated in an open label way who had failed other treatments. So potential treatment that we might try. We've talked about combination therapies. There was a recent report from Chicago, Dr. Richard Burt, suggesting that a number of patients who had undergone autologous stem cell treatment, and he reported about 80% after a relatively short follow-up period, were able to come off all of their immunotherapies and remain attack-free. I think this is a preliminary report and more needs to be done to study this. I've personally seen patients who have failed autologous stem cell transplant that had been administered for other diseases like cancer, and then had relapsed with neuromyelitis optica afterwards. So I think we need more experience before we could recommend this. I think a very important strategy is going to be T-cell-based strategies to try to tolerize the immune system, and a variety of approaches have been suggested, expanding regulatory T-cells ex vivo, creating dendritic cells that are immunosuppressive by transfecting with by proteins, by genes for aquaporin 4 proteins, and basically antigen-specific targets. I don't think these will be first-line treatments, but of course, now that we have very effective control, the question arises that if we have very good control of these diseases, how long will we maintain medications such as the new targeted therapies, and can we do anything that modulates or tolerizes the immune system in a way that long-term immunosuppression or even targeted therapy would be necessary? I won't go through all the other potential strategies. Many of these are for the future. Let me just go to my conclusions. There are relatively few established treatments for acute attacks. High-dose corticosteroids are generally accepted as first-line treatment, but plasma exchange is an important rescue therapy. And some would even suggest that starting plasma exchange simultaneously with corticosteroids or as first-line treatment may be as good, if not superior. We have multiple options for long-term therapy, but we have very few head-to-head comparative studies with existing oral therapies, and certainly none amongst or between the various targeted therapies. All regulatory approved options seem to be highly efficacious. It's hard to compare for efficacy because of differences in the clinical trial in enrollment criteria, attack definitions, and whether or not concomitant therapy was allowed. So I really think we have no data to suggest that one is superior to the other in terms of efficacy. No short-term safety issues have been demonstrated, but I think we still need to be concerned about long-term safety, especially risk of infections, and a lot of difference in cost between the existing treatments and the new treatments, which are extremely expensive, as I've mentioned. Monitoring for efficacy is mainly clinical. It's worthwhile monitoring immunoglobulin levels for inebilizumab, and if the immunoglobulin levels drop below 1.5 grams per liter, it might be reasonable to consider IVIG as replacement treatment to prevent infection. But the value of MRI monitoring and serum GFAP monitoring, which I think is promising for the future, that remains unclear. And on that note, I'd like to thank you for inviting me to give this presentation. All the best.